Good morning, everyone. Thankful to those who have arrived on time. And this Foundation Day celebration is slightly different, but we do not have any what is called peer-to-peer gravity. So there is no formal evaluation, there is no formal this academic test. This deadline session is dedicated only for this discussion, and anyone and everyone is free to ask anybody any question interrupting the session in between. So it's only this discussion, and so and this session, this academic event. So we screen all women and all pregnant women should be screened, and we know that screening all pregnant women will identify some diseases in one group, another disease. It may be common, it may be rare. So the commonest one is anemia, and few days back we had those conclave now to anemia. And KGMC reported 80% of their women in labor are anemic. The literature says that around 50% of women, pregnant women are anemic. So we should not forget anemia while treating these patients or seeing these patients. So diabetes and gestational diabetes next group, and RH negative, because that's the level of at least our department. So, and this UTI, urinary tract infection, we should never forget, so that we can treat them and prevent a preterm delivery. So congenital malformation, we should not shift onto the second slide. The first slide is most important one. The second slide of congenital malformation, syphilis, hepatitis B and C, all of us screen them. But what we have jumped onto is this Down syndrome. So the first session is on Down syndrome, screening, use and misuse of those. Hemoglobinopathies, yes, we have got a case of it. So blood group universal screening, please remember the RH negative, immediately go to the test. Yesterday we have seen a patient who was given, whose RH isoimmunized, was given an injection IUD. So this should not be done. If ICT is positive, then the woman is already isoimmunized and this should not be given. Next is this hemoglobin, at least 4 times. Please, and there is should be minimum 4 weeks gap between 2 tests. And we is we should not have the warning. Then comes diabetes, and we have started practicing it, and all of us do that. And Ministry of Health and Family Welfare also approves that. Hepatitis B antigen or HBsAg. If the woman is positive, we need to know that the baby has to be immunized. And with both vaccine and immunoglobulin, there should be 12 hours, within 12 hours of birth. So if a woman is delivering in your center with hepatitis B, we should give this vaccination option. Thyroid, I am not going on to detail of it, it's recommended. Then pre-eclampsia, we have got a session on chronic hypertension. But our session on ultrasound will identify the pre-eclampsia, how to screen them, and preterm also. So, to sum up this screening program, we have like pre-eclampsia screening may cost around, this cost is approximate cost. So it may cost around say 3,000 rupees. Preterm will cost you around 500 rupees. Yeah, GDM will cost you 200 rupees. Then this Down syndrome cost around say 10,000 rupees or so. Initially it is 2,000 rupees. So we should not forget our the basics of it. So we may see, but then aneuploidy we do screen. We may see a pregnant woman who is Downs, or a baby, a mother who comes with a previous baby with Downs, or there may be 2 Down syndrome to a couple. So these are our practical experience of seeing it. So with this warm up of our brain, we get on to truly the use and misuse of serum screening, which we do before doing the blood group even. So I invite Dr. Ruchika to continue with our case presentation. So we will be having 3 case presentation showing you how this test is, and I will be summing up with what should be we practice in our routine and day-to-day life. So Dr. Ruchika, please.
Thank you, ma'am. So, okay, so now we'll be starting with our very first case series of the day with the topic of aneuploidy screening, the uses and the misuses of it. The foremost encountered referrals for all expert obstetric setups and for us as well. I have 3 capsules for you. The first patient, Mrs. A, 24 years old, primary grandma with a singleton pregnancy, married life of 2 years, and a past history was not significant in such a case. She came for a routine antenatal visit at her treating obstetrician. NT&B scan was done, followed by combined screening test, which came out to be low risk for trisomy 21. Here we can see the report for the patient. The Down syndrome risk for this patient was low risk. Subsequently, she was advised to have an anomaly scan, that is TIFA, and no soft markers were noted in it, following which she was advised a second trimester screening. The quadruple marker advised came out to be high risk for trisomy 21. So to summarize, she did a first trimester serum screening, which was low risk. Then she was advised a second trimester serum screening. This came out to be high risk. Obviously, the patient was worried and she was referred to our side for further management and counseling. So we saw that the second trimester screen was increased risk and first trimester screen was low risk for this patient. So the provisional diagnosis was primary grandma with 20 weeks pregnancy with low risk of trisomy 21 in combined screening and high risk of trisomy 21 in quadruple marker. So what do we do next now? We did appropriate counseling for the couple. Option of prenatal invasive testing was given. The pros and cons were explained. She opted for an amniocentesis procedure and the reports came out to be normal, luckily for her. And she had an uneventful antenatal period and she delivered an alive and healthy baby. So what do we need to know? First trimester combined screening is more sensitive and specific than second trimester quadruple test. Appropriate counseling, individualized for the couple also is extremely important. Patient readily do opt for prenatal invasive testing. The key takeaways from such a case were that screening has to be offered to all according to the latest recommendations. And first trimester screening followed by a quadruple marker screening is not recommended because it will result in an unacceptably high positive screening rate. Second of such case series, a patient, Mrs. B, we'll call her Mrs. B, 36-year-old female, gravid 3, 1 live issue and 1 abortion with singleton pregnancy, 16 weeks of gestation. She was referred to our site. She had 1 missed abortion, first pregnancy, second pregnancy, uneventful antenatal period, full-term section, and the female child is alive and healthy. In the third pregnancy, she came to our site with a serum screening as well as non-invasive prenatal testing report, that is NIPT, done simultaneously on the very same day, and she was referred. Both the reports were high risk for trisomy 21. So obviously the patient was very worried and we were also worried. And she came to our side and we saw the reports. The first report, that is the first trimester screen, and NIPT report, both were done on the very same day, that is 13 November. And both were high risk for trisomy 21. So the next steps we took were that she is now 16 weeks of gestation. First and foremost, we went ahead with the ultrasound. We found that the fetus had an absent nasal bone as well as atrioventricular septal defect also. The couple was counseled regarding everything, that is the screening tests as well as the ultrasound findings, and they opted for amniocentesis procedure. Amniocentesis was done on 8 December, and report unfortunately came out to be affected with trisomy 21. The report was explained, and option of termination of pregnancy was given to the couple. So what did we learn from this case? Multiple screening tests should not be performed simultaneously. It is unnecessary, irrelevant. Cell-free DNA, that is NIPT, is the most sensitive and specific screening test for the common fetal aneuploidies. It is still a screening test. It is not a diagnostic test. Prenatal invasive testing is supposed to be done if we find major structural malformations in the scan. In this case, NIPT was done. Now we get to see whether this was required or not required in such a case scenario. So the indications of doing cell-free DNA testing, which have been given by the guidelines and approved by various societies, are if the maternal age is 35 years or more, then we can definitely give the option of NIPT in the first day itself to the couple. Prior pregnancy with the autosomal trisomy, as in the prior pregnancy has been affected with such kind of aneuploidy. The known carrier of a balanced translocation involving chromosome 21 in either of the couple. If we find an intermediate risk in the serum screening test done priorly, and higher risk in serum screening in those cases only that the couple who do not want to have an invasive testing procedure. Coming into the third case, here we can see she is a 34 years old female, Bravo 4, Para 3001. Now she came to our side, this was a consanguineous marriage, and she came to our side with a history of previous 2 neonatal deaths of neurological abnormality. And after this, she came to our side for preconceptional counseling. She was not pregnant at that time. We counseled the couple, we evaluated her detailed reports, and we advised genetic screening for both the couple. And they were found to be carrier for the same mutation. And later on, we advised accordingly to the couple and asked her to come to us as soon as she conceives in the next pregnancy. In the next pregnancy, when she came to our site, we did prenatal invasive testing, that is chorionic villus sampling at 12 weeks of gestation. Luckily for her, this came out to be normal, and she continued with the pregnancy, and the baby is fine and healthy. Now she has come to our site in the 4th pregnancy as well. And now we are left to see what we do in this pregnancy next. So this is the 4th pregnancy. The couple counseled regarding the same as previously, and they again opted for chorionic villus sampling at 12 weeks of gestation. Prenatal invasive testing was done, and fetal sample for targeted mutational analysis was sent, which came out to be normal. Then we counseled the couple that they can go for microarray analysis to see for trisomy 21 and other common aneuploidies from the same fetal sample, which was taken out for doing CVS for targeted mutation analysis. And this also came out to be normal for the patient. So the reports were explained, and after overall antenatal visit, the patient was fine, and patient was referred back to the treating obstetrician. Couple again was advised a quadruple marker test, which came out to be intermediate risk. And she again came to our side, all worried and confused. All we had to do was re-explain to the couple what is the exact her individualized case, and such no further testing, no further serum screening was itself needed. And now also no further testing is required in such case, as her aneuploidy we had already ruled out by doing microarray analysis from the same fetal sample. So later on, she had an uneventful antenatal period. She delivered a healthy child. So the learning points from this case were that in such cases, we come across a genetic disorder in the couple or single gene disorder. Here we found that it was autosomal recessive with a 25% risk of recurrence. Prenatal invasive testing can be offered at 12 weeks of gestation. That is, we do chorionic villus sampling. And the same fetal sample, we don't have to do a second procedure for this. The same fetal sample can also be used prokaryotype or microarray analysis to detect trisomy 21. So the principle we follow is, if CVS is done and it is found to be affected, obviously we'll tell the prognosis and the situation to the couple, and the medical termination of pregnancy is advised in these cases. If the targeted mutation analysis, which is the known mutation in the couple, they are already carrying, this comes out to be normal, then we can go ahead and offer them a further testing from the same fetal sample for trisomy 21. And risk for trisomy 21 in such kind of pregnancies after ruling out a targeted mutation is similar to any other pregnancies with similar kind of high risk factors such as maternal age. So overall, when a patient with aneuploidy screening risk comes to our side, what should be our approach? If the first antenatal visit is in the first trimester itself, obviously we go ahead and do an NT-NB scan, especially NT. We have to have an expert sonographer for this, combined with a double marker. So we do a combine which has a very good sensitivity and specificity. So after doing the combined test, if the risk comes out to be more than 1:100, this risk is not, it is still arbitrary. We don't follow it universally. But if it comes out to be more than 1:100, then directly we should go and offer them invasive prenatal testing. If it comes out to be intermediate risk, then we have to look for other markers on sonography. And if it comes out to be low risk, that is lesser than 1:1000, we can do a routine antenatal follow-up for the patient, followed by a TPA scan and 18 to 20 weeks of gestation. So if we see for the intermediate risk that there are certain markers or abnormalities on the ultrasound, then we should directly offer them invasive prenatal testing. Whereas if the sonogram is normal and the patient has intermediate risk, then either we can do no intervention, or we can offer them NLPT, or we can do routine follow-up with TPA scan. If the patient is coming to us in the first antenatal visit in the second trimester, then we go ahead and offer them a quadruple marker along with an anomaly scan. So we calculate a final aneuploidy risk based on both of these. So if the risk comes out to be low risk, then we can go ahead and do a routine follow-up and a TPA scan if not already done. If it comes out to be high risk, that is more than 1:100, we should definitely offer them prenatal invasive testing and do the counseling for the same. If it comes out to be intermediate risk, that is between the two, then we have to look for the markers, that is soft markers on the ultrasound, or it might be a normal TPA scan. Accordingly, we do risk modification of aneuploidy risk, or if feasible, we can offer NLPT screening. But in those cases, if there's any other marker on the ultrasound or there's a major structural malformation, we don't offer NLPT, and we should again offer them prenatal invasive testing. In some cases, patients do come with the first antenatal visit after 21 weeks of gestation. So extremes of weeks of gestation have low sensitivity of quadruple marker. Hence, quadruple marker should not be offered in these cases. It will only lead to more confusion. But we cannot forget to rule out malformations by doing a detailed anomaly scan. Thank you. With this, I again invite Professor Mandakini Pradhan ma'am for further discussion, clarity, and practical approaches on coming across such patients.
So the dilemma remains. The first trimester is followed by second trimester. Low risk turns into high risk and subsequent scan. Can we integrate these first trimester and second trimester? What do we do next? We try to this 1 hour session, we have tried to clarify these and what is guideline and what needs to be followed. If we look into the number, is because of high risk in serum screening, confusion in serum screening. And then of them, almost half of them land in having an invasive testing. And we do 3 to 4 in every month after doing that. So unappeared screening always women happy persons, but then screening becomes positive. Definitely the mother is worried. But all screen positive are not trisomy 21. You should not terminate pregnancy till after all these academic discussion. Still we get to see one or two patients who have with screen positive terminate a pregnancy. But then we need to screen to identify all these 6 women and then identify who is truly having a trisomy 21 fetus. So we all of us know that maternal age we started with more than 35, less than 35, but that is gone. Then we have gone on to serum screening, ultrasound. Ruchika already has told you. So ultrasound plus serum screening, and the nuclear, that is cell-free DNA, is no more new in this era. We all of us practice this NIPT test. We do get occasional patients with triple test. Let's remove this triple test from our armamentarium. Let's remember only quadruple and NIPT or NIPS, whatever you call it. So triple test should be deleted from this screening series. And what is most important to remember is, if we are doing a double marker and a NIPT test, then the sensitivity is highest. So we should aim for this highest sensitivity. But if the patient comes to us in second trimester, then still we can do a quadruple test. Along with that, we need to integrate that ultrasound finding to increase our sensitivity. So double marker alone. Suppose we are not doing an NT scan, we are not integrating it, or we are not combining them. So it's only serum marker, gives you 60% pass. But still you can achieve a 90%. So have a good NT. And that should be actually appropriate NT. The next comes quadruple test. If we are doing alone, it may give you 75%. But if we combine with ultrasound, I will come on to what ultrasound to be integrated, and that will give you a higher sensitivity. So always aim for higher sensitivity. Sensitivity has got its own role. We have got 3 slides on it. So we need to know that any patient, like the patient had a double marker and an NIPT advised simultaneously, unnecessary wastage of money. So that should not be done. And we know that first trimester screening NP and NP should be proper, appropriate. Any radiologist or anyone who is giving an NP with picture not like this, then we, at least in our center, we disregard that report. So then we do not consider that double marker, the empty combined report, and we consider that all those, if the patient is in appropriate gestational age, we repeat the test as a whole. And ductus venosus, additional marker, nasal bone. One can see this nasal bone, so local translucency, nasal bone, ductus, and tricuspid regurgitation are other ultrasound marker that helps us. All of us should remember that there are certain parameters that has to be entered, and that has to be informed to the lab when we are asking for a double marker. And number of fetus, IVF pregnancy. Previous history of trisomy 21, diabetes, smoking, maternal age, weight, ethnicity. All these, if you are informing the lab, then you are getting a higher sensitivity. So, like here, it is previous trisomy pregnancy unknown. If it is no, then it is, you will give you better sensitivity and your report will be more accurate. So, next comes is gestational age and appropriate CRM. Here, at a CRM of 41 millimeter, the NT was taken and biochemical risk and all these risks were calculated, and it was combined trisomy 21 risk was reported to be more than 150. Then we repeat the test. So what is the fun of doing one test there and here and then repeating the test? So nuchal translucency and nasal bone needs to be seen. So here is double marker, which is done when the CRL was 41.1 and the risk of trisomy 21 1:50, we land in having, so we look into this on the CRL and if it is appropriate or not. If not appropriate, then we disregard. This was the patient that Dr. Ruchika was talking about, that double marker and NLPT done at the same time. This patient has this, when we did, she came to us at 16 weeks, this was few days back only. So the nasal bone is absent, one can clearly see it, and the gestational age is 17 weeks. By the time the patient landed with us is 17 weeks. And if you see this video, then one can see that there is ADST. So atrioventricular septal defect, there is a major cardiac malformation. If first time, sir, we detect that nasal bone is absent, there is ADST, then definitely we opt for straight away going ahead and doing invasive testing. Then unnecessary spending this amount of money in NLPT and double marker is not essential. So this patient turned out to be, this is on 12th of December. Like the reporting time is, the sample was sent on 12th. The report came on 14th of December, just 3 days back. The fetus is affected with trisomy 21. Must be one of your patient. So next comes is, here is a patient. This is again on last week only, this week only, same time. So 15 weeks, 5 days was referred as combined test big one in 78. So referred for invasive testing, but what did we see? We saw there is no cardiac activity. So when we are doing this test, this major and minimum things that we get to see, and that this if the cardiac activity is there or not, then the patient may be better managed, and acceptability of this test will be better. So so ultrasound may have major malformation or may detect IUFD. You do NIPT only age is more than 35. And only serum screening with NP has very, very less sensitivity, that is around 60%. So in second trimester, we advise for quadruple test that should be done in 16 to 20 weeks. As Dr. Ruchika already said, extreme of age, like 21 weeks, the sensitivity decreases. So the final risk is quadruple risk plus ultrasound. So what all are seen in ultrasound is, apart from the major malformation, the what is called as soft marker, or we stop calling it as genetic sonograph. So the markers that are seen are absent or hypoplastic nasal bone, aberrant right subclavian artery, if there is ventricular dilatation, a local fold, echogenic bubble, and mild hydronephrosis. And so these are all these markers, soft marker that are seen. If you practice, if you are doing your own ultrasound, you practice, then ARSA is not difficult to be seen. One can easily see it, and the good machines are can show you ventriculomegaly, the bilateral polyposis, and increase nuchal fold. So these are soft marker. So detection of one soft marker, then you try to look for other and malformation. Detection of two markers, that is an indication of doing invasive testing. And only one marker, then you go ahead and recalculate it. Now, how do you recalculate? You have got a baseline serum marker or quadruple test, and you have achieved a risk. And now you have got all these markers, and there is a likelihood ratio. The same has been depicted over here for better understanding, that aberrant or hypoplastic nasal bone has got a likelihood ratio of 6.5. So your risk will increase by 6.5 fold. So suppose a patient has got 1 in 650, absent nasal bone, moves her risk to 1 in 100. 1 in 650 increases by 6.5 fold. So your 6.5 or 650 divided by 6.5 becomes 100. So 1 in 100. Similarly, other. So nasal bone has the highest likelihood ratio. Then comes ARSA and other things. So we do remember nasal bone, ARSA, ventriculomegaly, and increased mucus cold. These are four things that gives more likelihood ratio. The rest of the things are very, very less. So we usually see absent nasal bone. Suppose the risk is there is no soft marker. Suppose I am very good in ultrasound. I've done an ultrasound. There is no soft marker that are listed. Now, what is the modified risk? 1 in 129, and modified risk is multiplied by 10, then that becomes 1 in 1290. Here you will be resting in peace. Like you will be at ease that your patient who had 1 in 129, now it is 1 in 1290. Further testing needs to be done. Here, one soft marker is there. So what happens is 1 in 129 and increases by 6.5 times. How do you calculate this? The lower this thing you divide that. So you get 1 in 20. So the final risk is 1 in 20. This patient you have to do invasive testing. So this is how we integrate our soft marker into our serum screening. So please remember how do we integrate our serum screening. So NIPT is another screening test, and it screens for common trisomy, doesn't screen for any other thing, and it is less sensitive in low risk women. So it has to be confined to, like, to get that 99% sensitivity, it has to be high risk women. So abnormal traditional screening result is followed by a normal cell-free DNA. You have gotten definitely abnormal screening test on your double marker. Now you are doing a NIPT, and NIPT comes as negative. Still the fetus likely to have chromosomal abnormalities, 2%. So probably at the end of it, we will have thinking that if serum screen is high risk, then we should not go ahead and remember that those flow diagram, high risk invasive testing. So there is no question of doing a NIPT in between. Even if NIPT is low risk, still there is a chance of 2% fetus having some chromosomal abnormality. So we should not, NIPT is restricted to that intermediate risk. Low risk, not essential to have further testing. High risk has to have invasive testing, otherwise this 2% you will miss out. And we have missed some. So that is why I'm emphasizing this. Suppose NIPT comes as positive, the patient is very, very worried. Will have sleepless nights. If you put yourself into that patient position, then probably we also will have sleepless nights. Pregnant patient, NIPT positive. Very, very this thing. See this, NIPT positive. What is the positive predictive value? That how many patients will have a positive report? If maternal age is set 20, then it is positive predictive value. So almost 50% you will get the type. Is 20. Since that time, still your 20% will still be normal for trisomy 21. So it is not that NIPT positive means fetus is affected with Brown syndrome and termination of pregnancy. It means that you need to do an invasive testing. It doesn't mean, and this table probably will help you in analyzing if maternal age, what is the maternal age? In a low risk, in a young age, the positive predictive value is less, and as the age increases, the positive predictive value increases. There are false positive and false negative in NIPT, and maternal event. Suppose mother is carrying something to do with chromosome 21. There is some abnormality in chromosome 21 which is not clinically manifesting. So that can give you a false negative, and there are some false positive that is reported worldwide: maternal mosaicism, maternal cancer, a transplant patient. we do get renal transplant patient being pregnant and then coming for follow-up. We need to remember this point. The vanishing twin or a twin who has had a demise. So those also will give you a false positive result. So in this category, we should not ask them for an NIPT testing. Or a patient who had multiple pregnancy reduction done. A common thing, but NIPT may be positive. So screening principle, traditional screening test for all risk. If you धीरे आराम से. So yeah, hope you were fine. Yeah, so traditional screening test for all risk. We should not start prescribing NIPT for all. It has to be like the slides also shows you that it is still it could be less sensitive. So high risk cases is Krusika already said that those high risk more than 35 previous history of trisomy 21. If mother is carrier of trisomy 21, balanced translocation involving chromosome 21, and intermediate risk. These are indication of. So traditional screening test is if after cell-free DNA, you should not go ahead and advise a quadruple test. We do have an amount of this thing. We only have presented 3. Concurrent or parallel testing is also not recommended at all. So invasive prenatal testing, 1 in 50, if you have soft marker, absent nasal bone, ARSA, any soft marker, that is an indicator. Don't sit down and recalculate. 2 markers, invasive testing. Risk more than 1 in 100, invasive testing. NIPT high risk, invasive testing. So these are 3 indications of going ahead and doing the invasive testing. The other indication is even if there is 1 soft marker, after integrating with ultrasound, ultrasound report integrating with the serum screen, that is an indication of invasive testing. So invasive prenatal testing, you may get a report, trisomy 21. So each patient should have an option of prenatal diagnostic test. For a patient, 1 in 1,000 may be high, and she opted for an amniocentesis, as we saw in that patient. In spite of all our counseling, she opted for amniocentesis. For a patient, 1 in 100, it may be that 99% fetus is unaffected, full. But doesn't for an invasive testing. We do see. So counseling is most important, and no irreversible decision should be taken on the basis of NIPT or on the basis of only serum screening. So to conclude, offer screening to all, do not mix and match. Mix and match in this is good. In soils are probably good, but not in this our practice. Combine serum screening with ultrasound, low risk only for high risk invasive prenatal testing, intermediate risk you need to do further testing. And this further testing is NIPT or integration of quadruple test, which none of the lab are doing. And I probably need to catch up with the time. We need to do with no. We should not go ahead and do further discussion. I can have 5 minutes for quiz and discussion. So integrated screening is like we keep reading it. What is integrated is you integrate first and second trimester. You withhold that first trimester report. Then you do a second trimester and you integrate both of them and then give a final report. So can you do that? Can anyone do that? That first trimester, suppose high risk, you keep on thinking, but do not disclose this to the patient. The lab will not disclose. So this is practically integration is not very this thing. So then sequential, the first and then second. I do not want to confuse these points. That first trimester screen, high risk, you go on to doing invasive testing. Low risk, no further testing. Intermediate risk, then you do the second trimester screen. That is what says. But in the beginning of your second trimester screen, you take this first trimester report as baseline, which none of our lab are doing. The contingent sequential is the best test, and I call it as intelligent sequential. Like we can't remember going out of this hall. At least I can't remember what is contingent, and to remember we call it as intelligent sequential. So we are doing sequential test that we will remember, and we are intelligently integrating the first report into the second report. So like integrating serum marker into ultrasound finding. So similarly, integrating first trimester into this thing, currently none of our lab are doing. So integrated first trimester, that one, the report which is not wise. So this one is step one also is not wise. So what is this contingent gives us sensitivity of 90%, which is like more than 90% is a quite good sensitivity. Probably days to come, labs may do this. If we integrate first trimester into second trimester, that will be better. So with this, we come to an end, and I